They are live.
Good evening and warm welcome to everybody to this first edition of the G.O.D, that is the Grand Ophthalmic Debate and Discussion. And I would now like to invite Dr. Himanshu Mehta to please take over to welcome the judges and to begin the proceedings. Dr. Himanshu Mehta, present.
Thank you, Manish. Thank you very much for being the opening batsman and organizing such a lovely debate this time. Friends, this is a very power-packed people which you are seeing from across the country, and it's going to be great fun. G.O.D.D, Grand Ophthalmic Debate with discussion and a lot of science and no nonsense. You have great speakers who are going to fight it out very well. They are all great friends, but below the belt, above the belt, everything is allowed when the debate is on. And it'll be fun to see how they present themselves and what their point of view about everything they are passionate about. It's all about ophthalmology, the science, and end of the day, the benefit for the patient. This is what we are looking at. What is the right thing that we should do at any given point of time? The pharma may say anything, the industry may say anything, the equipment manufacturers, the lens manufacturers will tell us many things. But end of the day, what the patient is happy and what the surgeon was happy about is what we are going to discuss. So we're going to have some good fireworks, good fun. We have a great panel of judges who are going to give us some excellent outcomes as to what is going on ultimately. Dr. Lahane, our patron in charge, is one of the best persons to judge what is right and wrong, who are the best people who debated. Dr. Ragini will be there, Dr. Ranjit Maniar is there, and Dr. Quresh Maskati, all doyens of ophthalmology and Bombay Ophthalmic is fortunate to have all of them together in the city of Mumbai and the Bombay Ophthalmic Association. They will judge basically on the content, which is the most important part, humor, of course, and the debating ability to present their case. Even though we might at times be overlapping one topic over the other, they may also be doing something else. But at the point when they are talking and contesting about a specific point, they'll be talking about that. So friends, we're going to be starting very soon on the first round of this very, very interesting debate, which we shall be having. It'll be whether you want to have monofocal and or a EDOF lens or a trifocal. And then the second round would be ICL, IPCL versus refractive lens exchange in a 40-year-old man. Now, this is a series of debate. The point that we are trying to do is not a monologue, it's a dialogue, and each one giving their very strong viewpoints. Each one of them have a great experience to talk behind, and we are going to be sharing some very good experiences over the years. And let's start with the first talk without wasting and much ado about anything else. They're going to be shooting directly and they'll be talking to the point so that they get their point across. Thank you, judges, for being and sparing your valuable time. Dr. Lahane, sir, do begin. A few words from you to start with.
Good evening, and I welcome you all for this debate. This was Himanshu's brainchild. You know, he has got so many brainchild. And out of that, this is one of the brainchild. So he wants that we should fight each other. And for that, he has called every one of us. And he has also called the Ranjit and Quresh. So when you are fighting, the Ranjit will again put some oil in the fight. And the Quresh will pacify, if I don't fight, he will put some water. So he has called proper people also for the fight. And I think we will definitely enjoy. He wants some science to be discussed. And since I think he joined as a president, he was very much behind me, ki sir, kuch karna hai. And I think in that kuch karna hai, I told him ki you are Amitabh Bachchan. Whatever you want, you can go ahead and do it. So we are. I'm very happy that he has started with this debate, and my best wishes to all the debaters, and for my opinion, all are successful debaters on both the sides. Thank you very much.
Thank you so much. Quresh, would you like to say a couple of words? Quresh, you're muted. Please unmute.
Yeah, I'm muted for a reason. I'm eager to hear everyone. So let's get ahead. Let's go ahead.
Ranjit, anything you would like to mention?
The brainchild, I just was wondering, is it child only or all legitimate children? You know, so it's like Himanshu, you are full of ideas, and combined with Manish, I'm sure we are going to have a lovely, lovely, power-packed scientific year. I wish all the participants all the best, And mind you, you are being judged. Thank you.
Wonderful. Mohan, what was that you were trying to call Ranjit when the meeting started? I hope you've not done anything otherwise. And Rohit Om Prakash had disappeared until now. He was trying to contact whom I don't know behind the scenes.
No, Ranjit sir knows about me, and he's been there judges of so many of my OPLs which I have
These
won.
days, we
So
don't
already
give cash.
the permanent deposit has gone
No,
to him.
no, it's only diamonds now, no cash.
Your deposit has already been used because he has already given you the top price so many times. So your quota is over.
Thank you very much, Rohit.
That's why Rohit was late in entering. He was trying to call Dr. Lane on the other side. All right, here we go. The first one, which we start with, is monofocal versus EDOF versus a trifocal in a 45-year-old MNC employee who has heavy laptop usage. The opening batsman today for monofocal, in favor of monofocal, Dr. Abhijit Desai. All over to you. Rules: 4 minutes. Each speaker gets 4 minutes. 4 minutes will be against. And you get a chance for rebuttal 2 minutes later. We'll have a grand discussion on that, and then we'll invite questions from the audience also for their active participation. Prizes will be given to the best team in either of these segments, and then in the first debate that we have 6, we have the runner-up, the second runner-up, the first runner-up, and the winner. And in the second debate, we'll have the first runner-up and the final prize for the best speaker. So we have a lot of prize, and most important for all the participants, there are a lot of prizes to be won. The first one who registered today is going to get a prize. The 50th one and the 100th one will get a separate prize. And anybody who asks smart, intelligent questions better than the crowd here, they get more prizes. So a lot of things to be there. Let's start with the fire. Abhijit, over to you.
Abhijit is in my team, so all the best, Abhijit.
Thank you, sir.
Yes, boss.
So let's have the disclaimer. The content of this debate is intended for general humor purposes only, and the surgeon assumes no responsibility for whether or not you get it. If you have specific questions about what is funny, consult your cartoonist or the humor professional immediately. Monofocals? Oh, please, hip hip hooray. Completely hip hip hooray. In a 45-year-old MNC worker with a heavy laptop use, a no-brainer. This is Newton. And you can see the normal crystalline lens out here with a reflex. Can anyone see rings or central enhancements on these? Why do I want to be God? I want to be good. Who in the right frame puts rings in the eye? Rings are meant for wedding. Rings are meant for Lord of the Rings, not for the eye. Monofocal users, most intelligent. We don't bother about angle kappa. We don't bother about angle alpha. We don't bother about Fuchs endothelial dystrophy or a PCR or aberrations or a eye tracy or a decentration or a retinal disease or a keratoconus or a tear film abnormality. Across all of them, monofocals work very well. Monofocal monovision using aberration correcting IOL, smart. Undercorrecting the aberrations, smarter. Increases the depth of focus without adding any dysphotopsias. You keep a target of minus 0.75 in one eye, no bother about pupil size, no problems with night driving, and excellent near vision. No visual disturbances at night. We are talking about no halos, no starburst, no strings attached whenever I'm advising this. No big, long chair time. I can see more number of patients, cater to a much more number of masses with these MNCs as well. Let's look at the optical bench halo measurements. In spite of everything, you can see that the monofocal has the sharpest focus out here. And that is what is required for corporate people. A 45-year-old MNC is going to be absolutely demanding about what he sees. He wants crisp vision. Even at 45, he's going to be comparing it to his normal vision. We are not talking of a patient who has just come into a cataractus age group. We are talking of a person who is already seeing crisp vision, and you're going to give him a non-crisp vision. I'm not bothered about the implantation axis or a PCR with a panoptics or a decentration or all these things at all. Damn it, I'm smart. I endorse multifocals. Do you? Thank you.
Excellent. Excellent, Abhijit. Great beginning. Thank you very much for your input. Over to you, Mohan.
Can I share my screen?
Yes, sir.
Abhijit, yeah, that's fine. Able to see my screen?
Yes.
Am I audible as well?
Very well. Very well.
Yes, sir. Yes, sir.
We can
Okay,
hear you
thank
well.
you very much, Himanshu and the BYA for the wonderful opportunity. My opening batsman, Abhijit, has done a wonderful job. You are talking about monofocal, EDOF and trifocal. Monofocal plus lens is what we are using. That is high-ans and Swiss probe is what I'm going to talk about. These are the 4 keys to the refractive surgery. Look at the 4th key. That is the 3rd and the 4th one. Just choose the best visual quality IOLs. Exceed the patient expectations. Under promise and over deliver. That is for the multifocal. In high-ans lens and monofocal plus lenses, you can do it the other way, and you always give the best quality visual IOLs. And this is the most important mantra. If you are able to understand this mantra, because this is a patient who's a 45-year-old young fellow, N6 is not the goal. Please understand. The goal is happy patients. And the goal is happy patient. You don't have to give them N6. You don't have to give them a good near vision. But the goal is happy because you give them good quality of vision as well. So this is a scenario, 45-year-old MNC employee, heavy laptop. He is not going to stop with laptop, ladies and gentlemen. He is going to drive, he is going to do trekking, he is going to play golf, he is going to work on the phones as well. He's got multiple, he's a very active guy, 45-year-old guy. He's not just going to sit in the laptop every day. So you need to make sure that all his visual requirements at every point of time is taken care of, and only the monofocal like high-ans lens and the Swiss probe lens, which I'm using now recently in the OPHTHALMIC group as well. Change is the only constant. You see there is a change of chief minister, and tomorrow what will happen? Even Rajnikant and even Mohan Rajan become the chief minister. The new necessity, what is this? The good intermediate vision. It's called the new middle. What is the new middle? Let us talk about the new middle. You can see the newspaper, the sales in Chennai. The Hindu in 2010, 5 lakhs, 2018, 3 lakhs. Times of India, 3 lakhs, it has come to 2 lakhs. What is the reason for that? Because many people are reading newspapers on the iPad and the tablet. They are not buying newspapers. The iPad and tablet distance is not 35 centimeters anymore. It is 50 centimeters or even 60 centimeters. The near point has actually receded from near point from 35 centimeters to 50 centimeters. Look at this unhappy multifocal patients. Music maestro Ilayaraja. I operated in 2007. Unhappy multifocal, Kapil Dev, everybody knows about it. See, Ilayaraja is not able to see distance, that is, they are not able to use the piano, and he is using glasses for that because intermediate is a problem. Kapil Dev is not able to play golf because he put a bifocal, multifocal lenses. This is the biggest problem. Please understand that the EDOF lenses also can produce glare and halos, much less. Ring lenses, as Abhijit rightly said, more glare halos, more photic phenomenon. Multifocal lenses, in my opinion, are for housewives, house husbands, and your mother-in-law. Okay? And more importantly, you can see here how my near vision has gone up. Reading a newspaper in 2010, how it is 35 centimeters. Reading a same newspaper in 2022 on an iPad tablet, it has become, okay, 60 centimeters. So there is a near point which is, you don't require 35 centimeters anymore, and you don't require lenses like EDOF or trifocal. And that is the reason why I thought, okay, this is a happy Swiss probe patient, my very good friend, golfer, intermediate near vision, wonderful. The high-ans works very well, the Swiss probe works. High-ans patient, monofocal lens all the way from Andaman. Again, a businessman, is an ophthalmologist from Russia who's very happy, who's operating regularly. And my cousin is general surgeon from IONS monofocal lenses, and he is able to do that because intermediate vision is really fantastic. More importantly, the contrast, the quality of vision is fantastic. Which IOL for the Superstar? The Superstar has got an ERM because of the old BRV. Oh, he'll go for a high-ans lens. I've already told him high-ans lens is the best for him. And
One time up, you have to wind up.
Yeah, the versatility of the IOL lens is something which is, this is my last slide. Okay, this is from the horse's mouth. Monofocal plus is the best option. And you can see EDOF trifocal, you know where it belongs. Okay, both Rohit Om Prakash and Ramurthy, and also the other Neha and Nitin. Okay, EDOF, you want to be a Rahul Gandhi or Narendra Modi. You want to be Kamal Hassan or Rajinikanth. You want to be Sachin Tendulkar or the versatile Dhoni. These are all the advantages of a monofocal plus lens. More importantly, the low cost, versatility, no chair time, and absolutely no problem at all. High-ans lenses, the monofocal lenses, plus lenses will replace the EDOF and trifocal lenses. Thank you, ladies and gentlemen.
Thank you, Mohan. Wonderful question. Very well said, well mentioned. Abhijit, there's a question from the audience. Dr. Nikhil Nasta is asking you, do the patient miss binocularity due to the micromonovision you have given them? What do you do for that? Quick answer, 1 minute rebuttal.
So this is basically about improving the depth of focus by using your existing aberrations. Lenses like Technis are actually correcting the entire aberration and not leaving behind a depth of focus. There are certain lenses which actually undercorrect those aberrations and give you a depth of focus. Let's not go into the companies which do that, but that's the trick to it. And most of these patients, even with a 0.3 minus 0.3 target, do very well with intermediate vision, and they don't have an issue with distance as well.
All right.
Yeah.
Thank you so much. Yes.
No. I aim for what is called micromonovision. One eye, that is the first eye, I always aim for emmetropia. The other eye minus 0.5. When I use the high-ans, the Swiss-Fob lenses, the patients are very happy. Please understand that the N6, N8, they can have at 40 centimeters, 50 centimeters. As I told you, the near point has receded, and occasionally readers, they can use it. Anyway, if we EDOF lenses, if you're going to use a lens like a VVT or a Symphony, you will require a reader as well. Why pay 4 times the cost and use a reader? You can have an high-ans lens or a Swiss-Fob lens with 1/4 of the cost. That's what I'm trying to say.
Thank you, Mohan. Thank you. We go to the next set of speakers. I invite Dr. Nitin Malkan on his view for EDOF lenses. Nitin is a prolific surgeon in Mumbai, very sincere, honest practitioner who has done great presentations and work for Mumbai and Bombay Ophthalmic Association. Welcome, Nitin, to the show, and please go ahead. The show is yours.
Thank you. Can you see the slides?
Not yet. Share screen down below.
Please share your screen, sir.
All right. Yes, we can see it now, Nitin. Yes.
Yeah, good evening, everyone. Yeah, I heard a lot about people talking about monofocal and singing songs about monofocal, but I believe in evolution. Here, the case is a 45 years old MNC employee who has heavy laptop use. Now, the likely symptoms for him to visit the clinic because he is not comfortable with working, probably due to discomfort with the near vision glasses, hazy vision, pricking, red eye after a few hours of work, burning, watering, etc. So I would like to study the lifestyle first rather than talking about this or that. Is the screen time more than 10 to 12 hours? I get the information more from the attending person with him, not from the patient directly, because they don't tell you the proper exposure time to the screen. Whether he has a disturbed and inadequate sleep pattern, is he having dry eye disease, comorbidity, is he a type A personality? I would like to see everything before I jump to any conclusion. because the given case, the examination may reveal cataract, or he may have a clear crystalline lens and just wants to do away with his presbyopic glasses. The freedom from glasses in absence of cataract, this surgical solution would be demanded, and I will not command it. But if there is a cataract causing the symptoms, the surgical solution should be commanded. And when we are talking about a surgical solution for this particular gentleman, I wonder why we do the debate on this. Only and only EDOF lens is the answer. Because Ribeiro and Kochner, as late as in 2020 Journal of Cataract and Refractive Surgery, they have defined the clinical relevance of the concept of functional vision in cataract surgery, that preservation of not just the visual acuity, but functional capacity should be the main indicator and goal of the surgery.
Why is the slideshow is not coming?
It's not coming?
No, it's okay.
Okay.
Yeah.
So, and we all know that presbyopia is a curse. Presbyopia is a chronic dysfunction and rather the first complication of monovision pseudophakia. It is a complication of a pseudophakia. It is compromising the quality of life, including the physical, psychological, social life of a person who has just started enjoying his life in the middle 40s, where he has earned enough, he has a disposable income, he wants to move around and enjoy the life in every sense. And then we are creating presbyopia. Visual function is more important than visual acuity. This was found out as early as in 2008 in British Journal of Ophthalmology, published the study of the aging. Globally, near vision problem has an even stronger impact on the patient's quality of life compared with the distant vision. Post-surgery improvement of the visual disability of the poor vision function is greatly impacts the quality of life. Look at this slide. There is a changing trend. Very recently, 2019, the survey was carried out in published in 2021 ESCRS Clinical Trends Survey, which indicates that presbyopia correcting lenses provide more satisfying vision for near, intermediate, and distance vision compared to monovision IOL. Look at the slide, which says that trifocal lenses were done in almost 62% of the patient in 2019, and extended depth of focus lenses were in 20% of the patient. In 2021, just after
45 seconds.
The number of the depth of focus lenses have increased in number. So the trend is increasing, and this is the type of the quality of vision, the mesopic vision and the scotopic vision requirement is more in today's generation because of the near work. And in this condition, good intermediate and near vision with no glare, halos, rings, or arcs in the distant vision with good contrast sensitivity is the need of the hour. And EDOF is the only solution, whether you select pure EDOF, hybrid EDOF, or refractive or diffractive EDOF, or wavefront shaping X-wave technology EDOF. My choice would be the wavefront shaping IOL, where active lifestyle of such a person for driving, golfing, running, playing outdoor and indoor games with no visual disturbances, good intermediate vision for complex near work and playing music, loss of contrast is minimal, mesopic and scotopic activities are well tolerated in comparison with diffractive trifocals and bifocals. The patient understands need for small reading glasses for fine prints, which you have
10 seconds, Nitin, you got to wind up.
Suitable for the patient with mild glaucoma or past history of corneal surgery. So evolution is the way of life, and we have to accept it. I rest my case. Thank you.
Thank you very much, Nitin. Thank you for a wonderful presentation. A lot of homework and hard work getting into it. Thanks for presenting your point of view. We have our next speaker, Dr. Rohit Om Prakash. Could you? Yes. Dr. Rohit Om Prakash is again a very, very popular and a wonderful human being and a great surgeon. He has done some great contributions to ophthalmology by giving some very nice science like the side port incision, then the flap sign, that if you have a rupture in the anterior capsule, if the flap mobility is there, then you know that the vitreous is not coming out. Some very important contributions. Welcome to the show, Rohit, and thanks for being there.
Yeah, thank you, Dr. Himanshu. I'm so thankful for inviting me over, and I'm so thankful to all my previous speakers because they have helped me. Dr. Mohan Rajan and Dr. The monofocal team, they have also helped me. EDOF IOLs are my choice. We have to realize that the basic requirement is visual requirement is distance, intermediate, near vision, extended or continuous range, quantity of vision, and quality of vision. Well, the next question is that what is the visual requirement of a 45-year-old IT professional? He is very much into laptop usage, no second thought. He has an increased life expectancy, and he's a very active person. Driving is there. He needs quality of vision, and he needs a continuous range of vision. So, and my choice is Vivity EDOF lens, which has a small curvatural change across 2.2 millimeter region, which shifts the wavefront to utilize all available light energy, and it doesn't split. So the halo profile is as good as a monofocal IQ lens. So he would not have any problem when he goes out. As far as the visual disturbances are concerned, patients who were not at all bothered by visual disturbances in global study showed, as far as the starbursts, halos, and glares were concerned, Vivity stood out as good as a monofocal Acrisoft IQ lens. So trifocals, they split, and the Vivity IOL, it never splits, it just stretches. So, the fluent reading speed across different font size with this EDOF lens is, you can see how the speed is better than even an Acrisoft IQ IOL. No clinically relevant differences in the binocular mesopic contrast was there when we compared it to the Acrisoft IQ IOL. So it provides, when you see at 50 centimeter, it is 20 by 32 width, and with a Vivity IOL, which is the EDOF IOL. So this is what is basically the requirement of this person. And if you do small bit of micro monovision of 0.5, the patient has even good near vision as well. So the Acrisoft maintained a good quality of vision as far as without spectacles over Acrisoft, even in dim light. So this is something which was seen. So another important thing is it gives full light utilization with monofocal visual disturbance profile. Another important thing is it's a naturally occurring continuous extended focal range. So for a 45-year-old man, there would not be any halos, the contrast and everything would be good. And if we have a mono, this is a visual outcome after bilateral implantation of Acrisoft Vivity extended vision intraocular lens. The uncorrected distant visual acuity was 97.5. Uncorrected intermediate visual acuity of 20 or 25 or higher was there in 70%, and 15% was there for near vision. But you have to realize one very important factor. If you do a monovision, it will help. I have implanted, you can expand it in those patients where there is a compromised corneal picture. So in these cases, the trifocals, they don't work. So these intraocular lenses, the Vivity works in these patients as well. So EDOF gives us in an active person, it gives us distant vision, intermediate vision, near vision. You can have it, but near vision is if you do a micro monovision. But mark my words, this individual requires more of an intermediate vision, and he doesn't require bumps in vision. He requires an extended continuous range, which is provided by this extended depth of focus intraocular lens. The quantity of vision is good, and the quality of vision is as good as a monofocal intraocular lens. So thank you very much, my friends. One small question, Dr. Mohan Rajan, is that if you go through the literature, most of the literature says that this Eye-Hans is a monofocal plus and an extended depth of focus intraocular lens also.
No, it's a monofocal plus.
It's a smaller brother of Vivity, which is a true extended depth of focus, which doesn't have any rings. There is no splitting, and it provides the best.
No, it doesn't come under the EDOF lenses category. It is a monofocal plus lens.
Yeah, so
Okay.
that's also another debatable point.
Yes.
So we are not talking about only Eye-Hans out here.
Well,
We're
this
talking
scope is
about
there, so many other lenses.
undercorrecting the aberrations on the cornea,
Yeah,
and even that works equally well as extended depth of focus. Maybe you're looking at correcting just around maybe plus 1.17 instead of a 0.27 of a thickness, and then you get that thing for the depth of focus. That really works well.
Yeah,
And
as
if
regards
you-
this monovision, I feel that you are asking the patient to do langdi ek pak se chalo.
No, sir.
micro-monovision.
When
No,
you
no,
are creating,
Monovision is not getting you to a 0.7
no,
or a
when
1.
the asphericity,
Yes,
just a
yeah.
minute, the asphericity came into existence
No,
to
sir.
control your higher order abrasions, and now you are creating defocus.
But you are doing the same thing with EDOF as well.
Everything
No,
is
you are
there.
not doing it.
Even
You are
with
not doing,
Vivity.
because it
EDOF
is
also
extended
doing the
depth.
same thing.
Even with
5 times the
Vivity,
cost.
Okay, friends, we are going to continue with the
5
debate.
times the cost.
This is the beauty of a debate. We want to, but let's have a chance for the last.
Himanshu sir,
Yes,
sir, there is an interesting question.
Yes,
which
I'm going to put
somebody
up those
who's doc-
questions. Please go ahead. I thought
Dr.
after the
Rishabh-
whole thing finishes.
Yeah,
after
Dr. Rishabh Shah has just put up a question asking whether a monofocal is better for a surgeon. Directed it to Dr. Nitil Malkhan. I just thought I'll bring it in here.
If I would go for surgery, I would prefer EDOF.
Yeah,
Why?
I have
What
I
is
have
operated
implanted-
now?
I have implanted Vivity EDOF in surgeons, in ophthalmologists, and they are so happy. It is to be seen, to be believed. I have implanted it in my mother-in-law, my father-in-law, in my cousins who are active drivers. And the only thing is, you should know how to use it. The first point which they said is under promise and over deliver.
No, that's what you should
I
say.
can see
Okay,
both of
let me
them.
answer. No,
I
I
can
want
see
to answer
actually
those
both of them
questions.
lifting their
No.
head up to see those things and answer.
I-
Come on, both of you need to get operated. Now, what are we going to do?
Okay, we need to have the third set of speakers together.
No, Himanshu, I want
past
to, because
45,
Rohit is
45.
talking some nonsense, I'll tell you.
Himanshu, Himanshu, they are past 45.
Okay, we hang
I'm
on.
telling you. No,
Okay.
I have operated several ophthalmic surgeons, general surgeons, laparoscopic surgeons, urologists, entire range. All of them are happy with Eye-Hans lens. The reason why,
This
because the
is the
Eye-Hans gives
classic-
fantastic vision for intermediate.
So I think,
not
Dr.
that.
Mohan Rajan, they would have
Yes.
been happier had you implanted an EDOF Vivity intraocular lens.
We're going to
Please
keep up with
understand,
this.
these patients, they're all drivers.
No,
They are
no,
right
no.
drivers.
All right, go on.
VVT in the other eye. That is the way to go.
Yes.
This is a
Put VVT in the other eye of
45-year-old
that patient.
No.
Okay,
We're
Ramurthy is
talking
there.
about
Keep up the
45-year-old
spirit.
patient.
Keep up the spirit. We are coming back to the spirit very soon. We want the third pair of speakers to come on. One thing, Nitin, I would like to say, I agree to disagree with that. Lagdi karke chalega nahi. I am very much for that. If you are doing a monofocal, a micro monovision is a great idea. I agree to disagree with you on that. Having said that, let's have the third set of speakers. We have the pretty Dr. Neha.
Ye bias hua, okay? You can't have a bias with the chair.
I think we did our bit before the debate.
Okay, so we will continue with the debate. Wonderful, great going. Thanks very much for all being live and making it even more livelier. Third speaker that we have is Dr. Neha Dholakya. Again, very senior surgeon in Bombay, an excellent craftsman and great viewpoint. She teaches a lot to the KEM world and the Bombay ophthalmic community. And we're going to see what she has to say on trifocals in a 45-year-old multinational company executive with cataract. Dr. Neha Dholakya, over to you.
So for me, it's just a no-brainer. Trifocals, obviously. What will this man need? He will need computer use, he'll need mobile use, he'll need distance use, and he will drive. Mostly if he's a multinational company owner, he'll probably have a driver. And look at all these activities that he's going to do. So somebody mentioned he'll want to trek, but he may want to check the map while he's trekking. He may want to hit the gym and check his playlist. He may want to see his smartwatch. He may want to play a sport which involves near, intermediate, distance, all three. He may want to play golf, somebody said, but he may want to check a message at the same time. He may want to take up singing as a hobby, and he may want to see a playlist from a phone. And as he grows older, he may want to do a Sudoku or a crossword. And here is not where he's going to, any of the previous lenses are going to help over here. I'm sorry. Here is a chart I have made. If you see, the first one is the monofocal, which gives you good distance, but very poor intermediate and poor near. And the 7 and 8 are what the intermediate people are talking about. And the Vivity is the extended monofocal. And number 3 and 4 are the trifocals. Now, what are the disadvantages of monofocal? Why deprive the poor guy from his near vision? He will have to wear expensive progressive glasses for the rest of his life because he has to use computer, making the man spend so much money for the next 30, 40, 50 years. And just see what happens. 2 case scenarios for distance, driving a car, watching TV, that's all that he's going to get. Intermediate, like shaving, using his computer, reading the newspaper or a business magazine, or seeing the mobile phone, you're just going to deprive him of everything. And then you say micro monovision. So out of 6 possible options with 2 eyes, you're just giving him 2 options, a distance with 1 eye and intermediate with the other. What about the other 4 options? And then coming to the Vivity lens or the EMV Rena. Look at the way this guy is reading. 66 centimeters, no way. Who wants to read like that? Near is the new far now. Okay, distance and computer, okay, but what about near? How many people in this audience don't have WhatsApp? And how many times in the day do you open your phone to check a message or anything? You want the poor fellow to carry a +1 reader along with him everywhere in his pocket? Very sad. Either he has to go for a progressive, or he has to carry his readers and keep wearing and removing them 20 times a day. And look at this. The EDOF lenses, both eyes distance, both eyes intermediate, but the near has completely gone. So you're depriving the poor chap from near completely. And then you say EDOF micro monovision. So, okay, 1 eye distance and intermediate, other eye intermediate and near. But one thing, what if 1 eye is slightly lazy than the other? We have lots of patients like that who have 1 eye. He may not get that range in that particular eye. Now we come to the trifocals. Look at this. The entire range from distance to intermediate to near, that too with each eye. This is brilliant. Who doesn't want this? And as when it comes to halos and glare, somebody just mentioned, well, how many patients have you operated in the past with trifocals, or even the restored or the multifocals that we got who are complaining today? It's a matter of neuroadaptation. It takes 1.5 to 3 months and the patient is absolutely fine. He'll be extremely grateful. And when it comes to chair time, somebody said, well, that sounds like a personal problem. I'm here to give the best what's there for the patient. And the previous refractive error, just think about it. If he's an emetrope or has been a hypermetrope, he'll be so happy because it's the first time in his life he'll be reading near without glasses. And just think if he's a myope, a low myope, who's used to reading without his glasses, you will make him a very unhappy post-op patient because that's something he could do all his life and now he can't. Now, if the surgeon is not implanting it because of the headache of counseling and chair time, well, that's not fair to the patient. Then you're just doing injustice to the patient. I tell him honestly that he's a very lucky man to have got cataracts at such a young age, because now he'll have the chance when his friends and colleagues can't read the menu, can't read their mobile, he can. So the advantages of trifocal are very evident. It's a continuous range of vision. And you're getting some now which you can start reading from 33 centimeters onwards, which is great for low myopes who've been low myopes previously. He can switch between distance, laptop, and without changing glasses. And he can go from Netflix to YouTube on the computer to WhatsApp on his phone within seconds without having to think of where to pull out his glasses from. He's not dependent on glasses 85 to 90% of his waking hours. He saves a lot of money on costly progressive glasses year on year. He will look younger. He's only 45. It's like a plastic surgery for a guy. Women spend so much. For this man, let him at least put nice intraocular lenses so that he looks young and he can wear nice sunglasses. The finish in a progressive pair of glasses is never the same as a pair of nice branded or good looking sunglasses. So give this guy a chance. So here I would say my mantra, use the latest technology available with the least post-op cylinder, do a femto if required, and here you'll have a very, very happy 45-year-old young man. So I rest my case. Thank you very much. I
Why
think
is
it's
the
a
emphasis
no-brainer.
on young here?
Thank you.
Come on. What about young? Do I want a YPT here?
Sorry?
No, I don't want a YPT here. We are talking about a computer and me. Nothing.
I like a YPT.
Nothing else. Nothing else.
Dr. Neha, if I'm not wrong, there is one big celebrity who had restored in his eyes. Dr. Mohan knows about him. He got both restores explanted.
Yes. I mentioned that, no?
Yeah. So she was talking about.
So I have expanded
Dr. Neha,
I have expanded 5.
I would like to say, Dr. Neha,
yes,
you have very conveniently forgot to speak about the contrast sensitivity.
Yes.
It is a major contributor to a good vision. And as I have shown the slide, today's 45-year-old MNC worker is 70% of the time has a mesopic or scotopic vision, where contrast is so important. And it is what is lost. There was no mention of contrast in your slides.
So the biggest thing is nowadays all the reading is on the screen where it is nicely backlit. So you have the mobile, you have the laptop, which are very well
Neha,
backlit.
your talk was brilliant, but you didn't mention about the contrast. Please understand, don't underestimate the photic phenomenon. Underestimate the photic phenomenon in these multifocal ringed lenses.
Why in the first place EDOF came?
Yes, once the glare and halos come, disturb
we were so comfortable with the trifocals and bifocals. Why EDOF came?
Is you want to play God, and I am not God.
All right. We are going. The going is great. We still have one more speaker, and there comes Ramamurthy. He's Dr. Ramamurthy. He doesn't need any introduction. We had a wonderful session there. He just completed 25 years of refractive surgery, and a great prolific surgeon, past president of the All India Ophthalmic Society. Some very good words of wisdom he always has, and he's going to be speaking to us on trifocal. He called me up a little while ago. His voice is not very good. Please bear with it, but he's participating without any questions. And I must thank all the participants. With one phone call, without anything, without any pursual, each one has participated with whole heart. And we have our next speaker, Dr. Kamal Kapoor. He's even more dynamic. I'm going to talk about it a little later. But thank you so much for being there. Dr. Ramamurthy, over to you. Are you muted, Ramu?
No, can you hear me?
Yes, now better. Yeah.
I'm very sorry, very bad throat. Himanshu insisted that I participate. My trifocal in a 45-year-old MNC employee, a laptop user. That's my premise. So what exactly is he looking for? He's looking for true vision, living vision for all distances, for near, intermediate, and distance. And not only for all distances, but all lighting conditions. That's in bright light, dim light, night light. So Nitin mentioned about contrast sensitivity. I'm going to take the bull by the horns and deal with that also. On all this person demands without a spectacle independence. Obviously, the only lens that can offer this kind of a vision is a trifocal intraocular lens. Let's look at the other options. The monofocal is not even there in the picture. You'll have an excellent vision for distance, but then it completely drops off as far as near vision is concerned or for intermediate vision is concerned. The conventional multifocal, a good distance vision, a good near vision, but intermediate vision, there's a large, very large trough. As far as the EDOF lenses that was being talked about, good for distance, reasonably okay for intermediate, then it drops down completely as far as near vision is concerned. My young 45-year-old is obviously going to demand vision for all distances, not a compromised vision where he cannot deal with his mobile phone, his reading books, etc. And even laptop for that matter often requires a reasonably good near vision. This is what is ideal, what is shown in green here. That is an excellent 6x5 or 6x4 vision for near distance, which comes to about 20, 25 or a 6x6, right through from distance to near of about 33 centimeters or 40 centimeters. When you get a good trifocal or a continuous range of vision intraocular lens, that is what this lens is able to offer to my eye. So essentially, what you have with a trifocal lens is an in the zone vision, that is a 2020 to 2025 from near to distance all the way. That's what a modern day computer specialist at 45-year-old will obviously ask for. What about quality of vision? We are not shying away from that. Let me refer to the two papers in which has been published and in which I was actively involved. In this first paper, I was the first author. This was conducted in 5 Indian sites in Shankar Nethralaya, LVPI, Narayan Nethralaya, Dr. Abhay Vasavada's hospital, and my hospital, the Eye Foundation. It's a clinical outcomes after bilateral implantation of a trifocal presbyopia correcting intraocular lens in an Indian population. 75 patients were actually enrolled. 67 patients completed the study. 94% of the patients were completely independent for all distances. Mind you, this was a prospective, well-designed study. 98.5% of the patients, 66 out of 67 patients were satisfied to very satisfied for all distances. Halos were reported because they are specifically questioned for it. 14% of the patients did say that they saw occasional halos, but was not really disturbed by it. Only one patient out of the whole lot complained of severe halos, which was constantly making life difficult for him. In spite of this, during the period of follow-up, not a single intraocular lens exchange was done. Based upon this Indian experience, a similar study was conducted across 5 continents: Asia, including Japan, Australia, Europe, USA, and South America. 6 prospective clinical trials worldwide involving 56 centers, 3 months to 1 year follow-up. 557 patients were involved in the study. The overall results were more than 86% of the patients achieved uncorrected distance, intermediate, and near visual acuity of 0.14 or 20/25 or better visual acuity at 3 to 6 months. Significant glare and halos, which often is talked about, is present only in 2.2% of eyes. Not a single one of these patients over a period of 1 year follow-up presented for IOL exchange. And as was already mentioned, essentially, obviously, there is a bound when you're splitting light, there's bound to be a certain amount of halos and glare, but then the brain adapts in majority of the cases to ignore what is not important, focus on what is important. That's neural adaptation. And younger the patient, better the adaptation is. And here we are talking about a 45-year-old who's undergoing bilateral better implantation. And obviously, he is going to neuroadapt over time and enjoy excellent visual acuity without the need for glasses over a lifetime. Let me show you the difference between an EDOF lens and a trifocal lens in a single patient of mine. Basically, what happened was this patient underwent a trifocal toric lens. Toric EDOF lens and this was exactly the lens which was implanted in this patient. And what exactly happened? The patient actually had excellent distance visual acuity, reasonable intermediate visual acuity, extremely unhappy because he ended up requiring a +1 diopter as far as near visual acuity is concerned. So what we did as the fellow eye of the same patient, we went ahead and implanted a trifocal toric intraocular lens. And what was the result of this? You can see excellent distant visual acuity, excellent near visual acuity, and a very happy patient who, in spite of a compromise near vision acuity in one eye, learned to live with this disability. So obviously, trifocal intraocular lenses is the way to go. For this 45-year-old young man, my message would be, you don't stop having fun when you get old. You get old when you stop having fun. And if you want to have fun and enjoy life to its fullest, my choice is a trifocal intraocular lens. Thank you so much for your kind attention.
Thank you, Rahul. Thank you so much. Despite not being well, you make great effort and great attempt by all the speakers.
Also, my 2 pointed questions to Ramamurthy sir.
Yes.
So one, in your study, whatever you said, we want this data of the people who are 40 to 50 years old. They may be going for presbyopic, clear lens exchange, or maybe having early cataract, because older age, trifocal, the life, the quality of life, the way they live is a different thing than these people. So we want the data of this age group only. And secondly, about the EDOFs. When we talk about the EDOFs, EDOFs are problematic lenses when you are using hybrid EDOF. Hybrid EDOF, diffractive EDOF, or refractive EDOF, or diffractive refractive EDOF. No.
Absolutely.
I don't say yes to these lenses. It is only the wavefront shaped EDOF.
Absolutely.
Wonderful.
Absolutely.
I basically, I would be lying if I say trifocus doesn't come with any contrast loss and there is no halo circular that is reported. But the fact is that if you look into your own patients who have had an excellent surgery after proper optimization of the optical surface, good surgery, good follow-up, good hand-holding for the patients, very rarely do the patients come across a patient who finds the glare or halo is disabling. There's a certain price to pay as far as the quality, as far as good vision for all distances is concerned. And in my own experience, I find it working very well. What I showed you is a very large studies, prospective studies, conducted in 5 very well-known centers in India.
But that doesn't for 45-year-olds.
No.
Today, our
It is for older patients, Ramurthy.
Not really. The inclusion criteria for these patients included right from 40 years to 65 years. And basically, the average age group of this patient was 52, not very far from 45.
And all those studies do not have a unilateral cataract. Most of them have a bilateral.
No, I'm not sure that it was mentioned that this patient has a
there is no study with a unilateral cataract, with a unilateral trifocal and a no.
How are you assuming this person has a unilateral cataract?
Okay, we have had great points of view. We are running short of time. A few questions from the audience that I would address to all of you. Dr. Preeti Kamdar asks, a 43-year-old lady, a diamond sorter by profession, has a posterior subcapsular cataract in both eyes, left eye more than right, vision 6.9, N10, left eye 660, N18. She shots diamond with the left eye with the loop. She wants specs. What would you do? Which lens would you put?
Got specs.
She wants specs, but she doesn't.
If she wants what lens? If she doesn't want what lens?
Eye-ans is the best.
Trifocals.
No, if she wants little number, VVT is the best lens.
Eye-ans is the best.
I have implanted in
Please, I beg to differ that eye-hans is a monofocal lens. No, it is not.
Perfectly happy.
I would be fine.
With either
eye-ans is not a monofocal. It's not a EDOF lens.
All right, got it. One more question from Dr. Ankita Mulchandani. Sir, which IOL will be giving vision closest to natural vision? Considering that the fact that patient is only 45-year-old and enjoying God-given vision.
Only a monofocal lens like
trifocal.
Closest to natural vision.
Sir.
No, sir.
Dr. Mehta,
Dr. Ramurthy doesn't have a voice, doesn't
no monofocal because you understand the lifestyle of these people.
Will give closest to natural vision.
Dr. Mehta, am I allowed to come in here?
All other lenses will give less than natural vision.
70% of the waking hours person is using intermediate and near vision. If you look at this age group, 70% of the time.
Put a monofocal with -2.
I can satisfy the patient 100% of the waking hours. I can satisfy the patient 100% of the waking hours. You are talking about 70%.
No, 70%.
I'm also satisfying 100.
All of you are still lifting your head to look at the computer. Come on. Even I am not.
Okay.
And even I am not.
Okay, now a most relevant question.
Dr. Mehta, can I come in with one point here?
Yeah, 1 second. One more question that I want is one question, a very relevant question to all of us. Dr. Rushabh Shah, for an operating ophthalmic surgeon, would a monofocal give better contrast and sharpness as compared to EDOF, especially while operating? And Dr. Sumit Lane has said if any of the surgeon here has been operated, which lens he or she has put?
I would tell the real answer for this is what we are missing is the contrast little bit compared to monofocal lens in EDOF. Now, when you are operating, you have so much of illumination available with
Illumination,
you.
That's what I'm saying.
That
So,
doesn't come in the
Absolutely
it doesn't
correct.
matter. It doesn't matter. Everything goes off. Even with the diamond assorting person, they are using a magnifying loupe. So
Yeah.
everything gets magnified with good light. So hardly it matters whichever lens. Most
You're
aberration.
not a debater. Where are you coming from?
Dr. Ranjit Manyar, you had a few words to say. Do the judges have anything to say?
Yeah, very much. A lot to say here.
Yes.
Kuresh, I'll go first. Yeah.
First.
You
Your hair is whiter than mine.
Yeah, thanks. These are lovely debating teams here. They are excellent wordsmiths. All of them are excellent wordsmiths because each team has changed the paradigm and very, very well to suit their particular brands of IOL. So the paradigms have shifted. And second is, what all of them have in common is they have been chased by the IOL companies, but not by the spectacle companies.
The pigeon is back.
So, Kuresh, anything you wish to
Yeah,
say?
yeah. I want to say, first of all, is
that
that evidently not much of communication between the speakers has taken place, because when we start the debate with Abhijit talking about monofocals and saying EDOFs are bad, and then his teammate, so to speak, comes out with monofocal plus is good, therefore monofocal is bad. And then we go on to Rohit
No, I
saying
didn't say
that
monofocal is
EDOF,
bad.
and Mohan says EDOF, his IHANS is not EDOF. So there is a lot of splitting of hairs. So on one side there is monofocal, then there is an monofocal plus stroke EDOF, then there is EDOF itself, that's the VVT. And then of course Neha and Ramamurthy talk about the trifocal. So according to me, it was a continuous range of vision, but
At
continuous
least
range
Dr.
of IOLs
Ramamurthy and I
that we saw.
were on the same page. The other teams
You-
are having
yes,
fights
yes.
inside the team.
I
only
agree.
now.
Neha and Dr. Ramamurthy were on the same page. The others were,
Absolutely.
it was a continuous
Perfect.
We are also on the same page.
Correct.
Come on,
You
you
all
wanted to-
first figure out what is EDOF, then we'll talk, because
Yeah.
you all are not
No,
agreeing
I want to
internally
give this.
only.
See, please understand
Right,
this.
right.
IONs.
But at the
Everybody
end of
says
the day,
IONs is a EDOF lens. IONs is not a
you're
EDOF lens.
still putting contrast down.
Okay,
Ion-
about the contrast and halos and glare and what you're
Now
saying, people are
that
complaining. Two
25-year-old
things, let me tell you.
MNC next year,
Only if you
after COVID starts to do painting, it's crazy. You can't.
only if you stare at that light will you see the halo and glare. Only a man from the psychiatric
No.
ward would do that.
Right, when you
Proponent
put
of
a- when you-
monofocals, let
what
me
Neha
tell you,
says is, when
the
you put
proponent
for a
of
patient
monofocals,
trifocal, please,
I have to
when
tell
you look
you-
at the light, please close your eyes. Don't stare at the light.
Let Kamal come in.
the whole
All right.
refractive
All right.
surgery
We
thing has come up.
have one more debate to go.
Sir,
Kamal, you wanted a point.
Sir,
Kamal,
sir, there is
Kamal.
one more interesting question which has appeared twice. Dr. Sumit has asked and another person has also asked whether anybody has considered using an EDOF in one eye and a trifocal in the other eye.
Yes, because when you put an EDOF in one eye, the patient is unhappy with the near still, and you have to go ahead with the trifocal in the other eye so as to satisfy that requirement for near.
Madam, you choose
EDOF
your
has lost.
Slides
you
also.
choose your EDOF properly. You understand the
Yes.
optics and then
Yes.
I have explanted one trifocal and put an EDOF, and the patient is very happy.
But
Can
one
I
is
come in,
how
Dr.
many?
Mehta?
You would have done 1,000 trifocals out of one. That is not
Let-
a good
let me ask a question to all the monofocals guys.
Exchanging.
Yes.
I have
This
explained.
is like Arnav Goswami show.
I have
Everybody speaking.
I have explanted trifocals. I have explanted bifocals. I have explanted monofocals as well.
Thank you. Now that's the point.
Problem is with your biometer.
These are a different thing. It's about an unhappy patient, and it's about how many times are you how you going to come across an unhappy patient with which IOL.
Absolutely.
I've had that.
That is the
Happy
question.
patient. Happy
About
patient.
unhappy
what is
patient, there are
important.
so many factors to be seen. Not just blame. Don't
All right.
just blame the
That's a big
technology.
discussion. That's a big discussion. But let me just make it easier. Monofocal is the oldest technology we had. Why did we expand on science? Because we went on to EDOF and we went on to a trifocal. So we'll discuss that. So there is progress in science. There is a logic why we wanted, and people got more greedy. So Dr. Lahane, would you like to mention a few points, sir?
I think the Quresh has not spoken. Quresh?
I spoke. I said that there has been.
Dr. Ragini has also joined. Ragini madam, आप कुछ Dr.
Dr.
Agini?
No,
Vivek?
sir, I'm enjoying the discussion. And I'm Ramamurthy, sir, please get well soon. And congratulations to Himanshu Bhai for his first webinar. And please, everybody go on. I'm just enjoying it.
Okay.
And
Thank
she's
you,
also
Ragini.
supporting her.
So I have heard
Hi,
out.
Mohan Rajan, sir. Hi, Rohit Prakash, sir. Malkan, sir. Hi, Neha. Hi, Manish. Hi, everybody. Hi, Kamal Bhaiya.
Hello.
Okay. So I
Manya,
have
sir,
heard,
and Kuresh, sir. Namaste, sir. Sorry for the interruption.
I have heard the discussion. The first question to me is if now Ragini told me that I have got one, you can say, spoke of the cataract. And after all this 6% discussion, now I will not go for cataract at all.
That's a good one.
Because see what happens, in the discussion, everybody says that this is better. And as you know, in the debate, if six people are pulling one eye, what will happen? So it is like that. So now one is saying the only thing in Neha's this one, whenever you are presenting anything, you must also say that these are the disadvantages. It should be included, though it is a debate, because it is a science.
Absolutely.
Like Ramamurthy, I think I appreciate what he said. In one I can go for the EDAP, and other I can go. But in EDAP also you must see that everything is not VVT. And when you are thinking of VVT, the patients are not affordable for VVT. So that also we must consider. So everywhere the VVT, okay. But what about you can say the other type of EDAP? So are they giving the good result or not? That is also important. Yes, multifocal patients are having so many problems, and that everybody should agree. So one day, multifocal is, I don't think it is going to go by longer. That may be any type of multifocal.
Correct.
That multifocality will be now joined with the EDAP like a VVT, curvatural changes, and that will be the future of the IOL. But I think for the discussion, I appreciate all 6 people who did an excellent, I think, presentation. The topic was given to them and they studied very well. So for the first, second, third, myself, Maniar, Ranjit, this Kuresh and Ragini, we will discuss according to how many people has approached and what is there in the bank. And accordingly, we will go ahead and give the result after the second discussion. And I appreciate this discussion. And thank you, Himanshu. Go ahead.
Thank you.
अभी तक कुछ नहीं आया सर, अभी तक कुछ नहीं आया.
आ जाएगा, कुरेश के पास होगा. He is a treasurer.
Okay, one question to everybody, minus this is not going to be considered for the final answer, but an honest question to each one of you. Dr. Ramamurthy, you are getting operated. Which lens would you prefer? Forget, you are not a part of the debate. Now, I'm asking you as an ophthalmic surgeon, a knowledgeable person with all the knowledge, which lens would you choose for yourself?
I would go for frankly, I would go for a trifocal now. If I was personally doing a lot of night driving, I would avoid trifocals. But I don't do that now.
So,
I have a chauffeur.
As a surgeon, as a renowned surgeon, you would prefer for yourself, minus the debate, minus anything, you would go for a trifocal. Not because you are speaking or you've been given the topic. As a matter of choice, you would do that. Nitin, what would you do?
I would go for an EDOF, and that is wavefront shaping VVT.
Absolutely correct.
Rohit, you again, no marks being given, Rohit, but please go ahead, genuine answer.
You know, if I can get my cousins with VVT who are active night drivers, my mother-in-law also, I would also seeing everything, seeing what the shortcomings of this is for the near vision, keeping definitely that in mind, still I would definitely go in for VVT.
Wonderful.
Sir, Dr. Om Prakash, that putting it mother-in-law, was it a revenge or you
No, Neha, it was not personal. Neha,
it was a gratification.
Neha, this is just a neutral question to each one, a serious point, because the viewers want answers from all the knowledgeable staff here. So please go ahead. What would you do in your case, Neha?
I would go for a trifocal because there is a specific area for near, and I have been a low myope, so I'm very comfortable reading without my glasses and would not want that taken away from me.
So you would go for a trifocal. right?
100%.
Given a choice as of today, you would choose the trifocal.
Yes.
Mohan, besides the humor, besides everything, I know
Actually,
you do a lot of
I am
trifocals.
enjoying micro monovision now.
Absolutely.
I have minus 0.75 now, the other eye 1.5. Okay. I'm actually enjoying not micro monovision, it's actually monovision. Okay.
So,
I will go for high ans lens and I'll go for a micro monovision because I've enjoyed this because I do a lot of night driving, I play a lot of golf. I want good quality of vision, and that is the reason why I'll go for a high ans with a micro monovision, which I've been enjoying all through my life. I want close to natural vision. Thank you very much.
thank you for your opinion. Kamal, I want your answer, please.
Okay, I've been trying to speak for some long time now. I do tend to agree with Dr. Mohan there. I have just operated my brother-in-law, who's a doctor by profession, 5 days ago. And I did a magnificent IOL, which is enhanced monofocal in both eyes. And another brother-in-law, another first cousin of mine, just like an elder brother, eye hands. And since I was one of the very high volume users of trifocals till 1 year, but in last 8 months, I personally used enhanced monofocals, more than 4,000 of them. So it is not about, I have done a trifocal and my patient is happy. I would flip the question. How many unhappy patients? How many times you need to have a chair time with your patient after the surgery? That's a very important question, which none of the audience is asked. If you have out of 100, 3 patients who are having glares, halos, contrast, the chair time and the stress they have is huge. So when you go for an enhanced monofocal, as Dr. Mohan said, that incidence of that chair time goes down practically nil. That's my personal experience.
Kamal, that's a biased opinion. You don't want to spend time on chair time. That's why you're doing it. But given a choice, 97 patients are happy. They are not happy.
Himanshu,
So, I'm not being biased.
those 3 patients will take the life out of you.
Absolutely.
Fair enough.
And with this, with these enhanced monofocals, sir, you cannot go
They
wrong.
will
And we
sit
do
in the
a
OP,
micro monovision.
they will
with
sit
these
in your
lenses.
outpatient and spoil the other patients as well.
Sir, dude, I give a micro monovision with these enhanced monofocals, and I've just done a study for one company. 68% patients are N6 unaided. 67%.
Wonderful. Abhijit, your point of view.
Yes.
So I am a very weird patient. I have a pupil of 1.5 millimeters. I don't dilate beyond 3.8 millimeters.
Anybody wants to touch his eye? No.
I can drive without glasses. I can read without glasses. I have a astigmatism of 1.5 in one eye and 2.25 in one other eye, and a sphere of 0.5 in each of them. And I would actually be happy to remain in the same.
So no surgery. Even if you
Nothing, and I can operate without glasses, and I can operate without glasses. So
Abhijit, if you get a cataract, Abhijit, question is, if you get a cataract, which lens will you put? That is my question.
First, which surgery will I choose? That is the issue.
Okay.
I would go for a monofocal.
Fair enough, because you don't deserve
And
anything.
I will
Because
not,
with a
and
small
I will not,
pupil-
and I will not correct my astigmatism either.
Correct. All right. Great. VC.
Most of the discussion about the trifocal is positive, and most of the surgeons don't prefer to put in a trifocal is because of the 2.2% of the patients who get the halos and the glare at night. The problem is, if the patient has a halo or glare, you have absolutely no solution.
Yes.
VC. My question now is no discussion. What would you put? Would you put which lens would you prefer? That's all.
I would put a VVT lens.
Period. VVT. Kuresh, you disappeared. Kuresh.
VVT also there glare halos, sir.
Kuresh, which one would you after this?
In my own eyes?
Yes.
Absolutely. Yes.
In my own eye, I think I would go for a trifocal.
Wonderful. Great. Yeah. Manish, quick answer from you, Manish.
All the best.
Manish, you are muted.
Sir, I would prefer to go for eye hands.
Wonderful.
Actually, Himanshu, you should be asking them, what would you put in your wife?
No, that means there you prefer to have a scotoma at certain places. So I'm not going into that.
I refuse to answer this, Abhijit, because she's also tuned in.
Okay, Samresh.
I don't have much of. I'm not an avid reader of print, so I would go with the VVT. That will give me a good range of vision for my day-to-day activity.
Sir, Dr. Lane, sir.
I think we need to move on to the second topic.
Yes, we are just a quick, because it's a very vital question for everyone.
Whatever Ragini decides.
Okay. All right. Madam, what would you put in his eye?
So that is exactly what I was putting up my hand for. I don't know what lens, but I have one question. So 2-3 years back, we were putting trifocals, panoptics in everybody. Now Vivity came into the picture and we are putting Vivity. What I'm wondering is, once you do the cataract and another lens comes into the market, then there's always development. So I'm really very scared, frankly speaking, because, you know, in my relatives and all, we have operated, we put trifocal. Now my bhabhi got operated, sir put VVT. So, you know, there is always advances. I know VC sir was putting trifocals. Now he's putting VVT. Then what next? So I'm really worried. I'm really scared.
In next 6 months, madam, before a new lens is introduced in next 6 months.
Go for high hands.
No, more.
I will do it for you.
Sir.
I will do it for you.
Another advantage,
no
Dr.
prompting.
Himanshu, is that the enhanced monofocals can be mixed and matched with most of the lenses.
All right. So we go to the next topic. We go to the most important topic. Thank you so much for a lively discussion. Please don't leave. We are going to have much more fun. The second topic which we have is ICL, IPCL versus refractive lens exchange. And who else better than Dr. Kamal Kapoor to start with on the pitch? IPCL, one of the highest users of IPCL in the country. Mohan, over to you. Kamal, over to you. Sorry.
Okay. Thank you, Dr. Himanshu. And I think I just feel so lively, you know, I like to kind of push my point forward, thoughts forward. The platform is live with fire. So many speakers, you know, firing phone cannons. So interesting topic. And it's something very close to my heart. And this is what I practice in, is my screen visible?
Yes.
Okay. So just a minute. There it is. Is it visible for all?
Yes.
Yes, sir.
Yeah.
Yes, sir.
So we have a 40-year-old patient, which of course, as an afterthought, I asked Dr. Himanshu, supposed to be a myope. How much myope, we don't know, but we're presuming is let's say moderate myope, -4, -5, whatever. So ancient wisdom says, in any surgery, when I did my internship and a house job, my chief surgeon, general surgeon said, do not sacrifice any human tissue if you don't have to, and if you can save it. So starting with that premise, and this is since a refractive lens exchange, I'm presuming though there's no cataract there. So are we wasting this lenticular tissue, which is still functional, which probably will have 10 to 15 years of more life to it before it starts getting into a DLS grade 2 or a grade 3 or some opacities? Can we save this? So what are the points against refractive lens exchange? It may not be an ideal surgery for most of the high myopia patients. And we know because some of these myopic patients have tendency for retinal detachments, surgical issues of very, very deep anterior chamber while operating. Suppose you're doing a very high myope, they can be very weak zonules. The bag size can be big. What about if there is a toricity and you are trying to take care of some toricity, the bag size being large, the lens may not be very stable. Appropriate lens power calculation, because there can be some aberrations in very, very high long axial lens. As I've already mentioned, there's an increased risk of retinal detachment. So juggling with the formulas, IOL formulas, you can have irrespective, you can have the most perfect formulas, but all will agree. They may not answer it here on the debate, but you don't get bang on every time. But when you do a phakic lens implant, you are just correcting the refractive error. And you cannot go wrong with the refractive error. Yes, I agree. For most of my friends and audiences who are not doing a lot of phakic lenses, what I'm saying might sound a bit odd, but the reality is, if you are a good cataract surgeon, phakic lens is a cakewalk. What you don't require is, the best part about this technology, it's reversible. It's absolutely reversible. So that is my biggest pitch. Suppose, God forbid, my patient is not happy. 1.0001% chance. It's reversible. I cannot say the same for a refractive lens exchange. Now, demanding patients, what if the patient has already got some refractive surgery done? Calculation of IOL formula in these patients also is tricky. So, you know, more than 3,000 cases done, and I do this regularly. My cutoff for a refractive lens exchange is 50 years plus. I do not touch any crystalline lens if the lens is crystal clear and there are no issues with the lens till the patient crosses 50 plus. Now, the best part, phakic lens, which has over Relax, is that it is reversible. Now, my friends, do not forget this. This is a very, very important tool for the surgeon. We all were talking about unhappy patients. What if the patient is not happy? What if the patient has photic glare or something? You can take care of that in case your patient is unhappy. So more than 2 lakh years, 2 lakh phakic IPCLs have been, IPCLs been put. A proven track ability. Now, what if the patient also wants some near vision? Till now, we are talking about correcting the myopia. So what I do for these patients is, suppose the patient is a high myope, -6, -7, -8, -9. I undercorrect both eyes by 0.75. And you'll be amazed. These patients are 6'9" and above, both eyes open, and they are doing a beautiful vision of N9 or N6 in some of them. My tall patients are very happy with N6, even if they are high myopes, because I bilaterally undercorrect them slightly. So that gives them a good lead time of few years before they have a problem. I can also do a micro monovision with my phakic lenses. I do both the lenses. Or I can actually use a presbyopic IPCLs also, though I've not done this in this particular age group, but that can be done because, the ring size is smaller. The chances of loss of contrast are far lesser. But my first 2 choices would be my ideal choices. Now, as Dr. Lahane said, and as Dr. Quresh and Dr. Maniar said, nobody's talking about the flip side. The flip side here is, yes, there will be some cases where I will not do a phakic lens. These will be the cases. What if the patient has got, myopia due to the index changes of the crystalline lens? What if the endothelial count is less? What if my anterior chamber depth is bad? What if I have posterior synechiae? My angles are less than 35. 600 microns and above, more of a crystalline lens size. I do not have a dilating pupil, which doesn't dilate well. If I have a pre-existing issue with the cornea. So these cases, yes, I might consider not doing a phakic lens. But if these things are not there, my phakic lens would be the first choice. As I said, salient points, shallow anterior chamber, low endothelial count, post-uveitic cataracts, history of glaucoma, posterior synechiae, any amount of lenticular opacity is a big no for me to put a phakic lens. I would rather do jump over to the opposite side of the debater. Now, the best part about a phakic lens in these patients is all crystalline lenses have some dynamic ability. I am 55 and I still don't wear glasses, though I'm a hypermetrop. So that is the dynamic state which I have. My lens still accommodates. So why am I depriving my patient of that some amount of dynamism? So if I take a natural crystal lens out, these patients would still probably retain some dynamic accommodation. So faster recovery, and the complications can be worse with a cataract than with a phakic lens. You could have endophthalmitis, capsule rupture, PC rent, vitreous loss, cystoid macular edema, post-refractive errors, endophthalmitis, CME, whereas ICL or IPCL also, yes, you can have complications, but the rate of endophthalmitis, posterior capsular rupture is less. And God forbid you have a cataract, you can do a crystalline lens exchange, but that is 1 in thousands to be seen. So I think I rest my case. Thank you.
Thank you. Thank you so much, Kamal, for a wonderful presentation. Great clarity about all your thoughts. We have to give us a counterpoint of view, Dr. Samresh Srivastava, who's going to tell us that why is a refractive lens exchange in a patient, a 40-year-old young man, better than doing an ICL, IPCL.
Am I audible, sir?
Yes.
Yes. Thanks a lot for inviting me for this. I think Dr. Kamal made a great point with whatever he said, and I value all his comments on his assessment of why IPCL or a phakic lens is good. But in all justice, I don't push any of these patients for any surgeries. I don't push any of these patients for surgeries. It's only when the patient says that I can get a surgery done and I will get a surgery done to get rid of my glasses at 40 years of age is when I will start to understand what needs to be done for the patient. So there's no pushing the patient over the edge. Whatever you do, explain to the patient what's being done and what the outcomes are going to be like. He discussed very clearly about myopia. And this is assuming a 40-year-old myope walks into your clinic. But in my assessment, the chances of a moderate to high myope walking in at 40 for a glasses correction is not as common as hyperopia or decompensating hyperopias walking into the clinic, and they want glasses correction. And I am one of those cases that's been emetropic throughout my life, but now I've started decompensating. And I realized that I have a latent hyperopia, which is now coming up at 42. So I'm bracket that is being discussed here. You can see a decompensating hyperopia from far away because they're not happy, they're tired, they complain of headaches, they can't fixate. And you can't do an ICL for these patients. You can't do an IPCL for these patients because what are you going to treat? You're going to treat the manifest refraction today, or you're going to treat the refraction that's going to come 6 months down the line, or treat the refraction that's going to be the eventuality. And how are you going to mini monovision these patients? Because you really don't know where they'll end up at this situation. The range of vision is a big bother for these patients. You cannot target any range, and it's particularly the near ad and the intermediate vision in the computer is what the complaints that they're coming to you with, and not necessarily distance half the time. So 40-year-old myope, very late in age to come for a refractive correction, and he therefore deserves a second chance to correct all his problems. And a 40-year hyperope, there is no solution with an IPC. So if a person has waited so long in life, for 40 years of their life, to get their glasses off, hyperopia, myopia, whatever, why give them a half-hearted solution? Why not take them all the way and give them a full solution to the problem once and for all, rather than changing their refractive corrections and giving them a sort of stopgap arrangement? Because the presbyopia is going to jump up from very low, and I'm using a 1.25, but I know that because I have a cyclorefraction of 1.5, I'm going to go down to 4 at some point in time. And it's not going to be a great idea to treat me with an ICL.
Good evening, friends. A very warm welcome to our channel.
More often, when you really critically analyze these patients who are coming up, you will realize a lot of the problems start from internal aberrations, which means that the lens has already started to age. The fact that these patients are presbyopic or pre-presbyopic is a classical example that a cataract, although not clinically manifest because it's not seen on slit amp, is obviously there. Because, I mean, what else is a cataract but a progression from a clear lens, which is accommodating, to a non-accommodating lens and to an opaque lens eventually. So there is a cataract that's building up in the eye, and that we cannot deny. So why push these patients in a short span of 10 to 20 years at max, from 40 to 60, from an ICL or an IPCL to an intraocular surgery, and 2 traumas in such a short span of time? I don't think anyone deserves such quick succession surgeries in a very fragile tissue like an eye. I do understand that there is issues, particularly with myopia, because the disease spectrum and progression could include things like glaucoma buildup, cataract, manifest cataract, as in a clinically visible cataract, or a retinal detachment. I think all these things are easily treatable or easily manageable if you do a thorough evaluation. If you have a retinal issue, pre-treat with a retinal barrage, invest in a good doctor who can, good retinal surgeon who can consult and treat these patients. If there's a possibility of glaucoma, I don't think any surgery needs to be done for these patients, IPCL or lens exchange. With the advancement of techniques and technologies, surgery has become extremely predictable, particularly with phaco, because it's tight, closed chambers, and with newer machines with active fluidics, you can really maintain the chamber. It's the chamber collapse during the surgery, which is our fear in refractive lens exchange, which can cause a potential of a retinal break or a retinal tear. But if you keep the chambers formed and you do a viscoelastic exchange when you're doing a surgery, chances of you trampolining that posterior capsule anteriorly and possibility of having a retinal issue is actually clinically negligible to none. And we've all seen it in our cataracts. How many of our cataracts in today's date and time with modern surgeries and modern machines do land up with retinal breaks or cystoid macular edemas and so on and so forth? It's negligible. It's probably as good as it would be with putting a phakic lens in the eye. And like Madam said, I mean, everyone deserves to look stylish forever in life. So why not, enjoy a good range of vision, full range of vision. At 40, they're heading towards complete presbyopia in the next 5 years. And nobody likes presbyopia and nobody likes progressives. It's a compromise, and why should one have it? So the final solution is to hang Hitler and be done with, that's the final answer. And with that, I rest my case.
Thank you so much, Samresh. Great point of view, what you're mentioning. Nobody likes multiple surgeries. We have our next speaker, Dr. Vinod Mehta, a leading practitioner in Mumbai with loads of experience and wisdom. He's going to talk to us on ICL, IPCL for in a 40-year-old male. What would he do?
Hi. Am I visible and audible?
Absolutely, both.
So ICL or IPCL versus the refractive lens exchange in a 40-year man.
Sir, आपका presentation नहीं दिख रहा है.
1 second. Okay.
No, not yet. We see.
Please share your screen, sir. We can't.
Yeah.
Sir, on Zoom window, there is a green button, sir.
Yeah,
Can you
yeah.
click on this?
It's share. I've
And
done
pop-
it. It
And the
says,
pop
yeah,
and the pop-up will come, and there is a blue button. You can click on that.
okay.
Not yet. We see.
You will have to click twice, sir. First the green button, then the blue button.
Amresh, you are allowed to hit under the belt, at a time like
I
this.
did it. I did it.
Rohan, come on. Give it to him.
No, I
He's
mean,
not
it's a
40 years old,
no-brainer.
so I can't give it to him. sir.
I'm going to be making the points that sir had made in his presentation. He actually made the task very much easier because all those points are already covered about endophthalmitis and TAS. Why would I want to, subject that patient twice over to that risk? The risk becomes 2 times rather than it being a 0.5% in a normal surgery. It becomes 2 times when you expose that patient twice to
Are you getting your
surgery.
slide?
I'll be making those points.
VC, are you getting your slide, those?
No.
So should
Sir,
I?
I'm sorry, but I'm not getting it on the.
Let's have Rohan speak now. You manage yourself. You have 4 minutes to organize yourself. VC.
I don't think I will be able to organize it because I've been
Okay,
trying.
then go ahead. Give your case. Give your case without slides. Go ahead.
Okay. So the point is that in a 40-year man who comes to you for presbyopia correction, what I feel is instead of getting into the treatment part, I want that patient to experience presbyopia first. I want him to struggle with the presbyopia so that he understands what problems he has with presbyopia, and then he will probably appreciate my treatment. And my treatment is going to be an ICL or an IPCL. Now, why do we want to kind of remove the optically good natural lens? This lens is serving the patient so well, and we do not have a good replacement for this natural lens. So why do we want to replace the optically good lens with an optically compromised trifocal lens? And what happens is that most of the time, if the patient lands up with the halos and glare, I have seen a lot of my patients getting a YAG capsulotomy done for an absolutely transparent posterior capsule. And this is increasing the risk of retinal detachment. First is the pseudophakia, removal of cataract, that increases the risk. Then the YAG capsulotomy, that further increases the risk. So why get into a refractive lens exchange? Why should we not spare the natural lens and instead add an additional lens like an ICL or IPCL? Now, ICL till now in India does not have a presbyopia correction, but IPCL definitely has a presbyopia correction, and it has a very wide range of adapters available. So that 1 to 1.5 decades of presbyopia problems can be overcome by putting in an IPCL or an ICL, provided obviously if the patient's eye are good enough for putting an ICL or IPCL. And once that is done, then he retains a good quality of vision. In fact, a lot of my patients, especially the high myopes, gain in lines in terms of the vision after putting an ICL or IPCL, primarily because the refractive correction has been done at the nodal point. One of my recent patients, who is a radiologist who came from US, was around 0.9 or 1.0, has gone to 1.5 vision. That is, he has got a supervision. And recently he SMS'd me that, "Doc, can I go for a scuba diving?" And he has already completed 3 or 4 dives. So my point is to give good vision, and if it is possible with the help of IPCL or ICL, we should give them that 1.5 decades of spectacle independence, after which we all have to undergo a cataract surgery. So my choice is ICL or IPCL. At the moment, ICL presbyopia is not available, but IPCL presbyopia is definitely available. So my choice is phakic IOL till the lens becomes bad and he goes in for a cataract surgery. Thank you.
Thank you so much, Dr. Vinod. Thank you so much for giving your point of view. Rohan, you're the last speaker. So we're going to hear some good fireworks from you to hear what is going to be happening. Would you do a IPCL or would you do a refractive lens exchange?
Refractive lens exchange all the way, sir. Let me just, is my screen visible?
Yes, go ahead. Go ahead.
So the topic on the floor of the house actually is RLE in a 40-year-old young man. There is no ICL, IPCL as far as I am concerned here. So refractive lens exchange, everybody now wants more. Everybody wants bang for the buck. Nobody is interested in wearing glasses. And the good old saying from back in the day that was always and always resonant with all of us Indians, fill it, shut it, forget it. That is what Hero actually started the Splendor on, and it is actually globally the best sold motorcycle for a reason, because it was fill it, shut it, forget it. And that is what our sort of thinking should be for each and every patient that comes to us. If somebody is coming to us, he is wanting longevity. That person wants that whatever be my age, be it 40, be it 50, in this case, we are discussing a 40-year-old man, that person does not want to undergo another procedure at any point of life. Put yourself into the shoes of that patient and tell me, tomorrow you want to go purchase a car, you want to go purchase a 50 lakh rupee car, and that showroom person is telling you that, well, the suspension will work for 5 years, but after that, it will need a overhaul. And I'm telling you this right away, that 5 years later, you'll have to again come back to the showroom and spend money. So nobody wants a quick fix. And in my opinion, in a 40-year-old who will be developing a cataract, and I will show you all the studies that show us that now, because now is the time that it has been over a decade that we've been putting ICLs and IPCLs, and they have started coming back to us with anterior subcapsular cataracts. The other point that was mentioned was about the risk of retinal detachment. So I have one question to everybody on this panel. A high myope, this particular gentleman comes to you with a dot PSC or a posterior polar cataract at the age of 40 or even at the age of 30. Would you operate this patient or would you not operate this patient? Everybody would jump in and operate this patient. Then if it's a clear lens, what difference does it make? If you will operate somebody who has a dot PSC, if you will operate somebody who has a posterior polar cataract, then why would you not go ahead and do a procedure in someone who has a clear lens exchange and wants that he has spectacle independence? So you see, I've pulled out a little bit of literature. 2018, this paper was there. In 2018, the incidence that they found of cataracts coming back in ICL and IPCL patients was about 1.5%. Now, so let's move ahead to 2022. This is when now it's become a decade old, and see what they found, that the incidence actually has ranged from 0.3% to 28%. And also in this article was written, it is directly proportional to the age at which the ICL is put into that patient's eye. So the higher the age at which you put an ICL into the patient's eye, the earlier the likeliness for that patient to develop a cataract and come back to you maybe 5 years later. Or maybe not come back to you actually, because you put an ICL in his eye and 5 years later he got a cataract because of the ICL that you put into his eye. The other thing that was mentioned was about TARS and endophthalmitis. You know, it's about exposing that patient to this risk twice over, once at the age of 40 and then once again at the age of 50 or 55. The other point that I would like to make when it comes to refractive lens exchange is customization. As we were discussing previously in the previous debate, here as well, we can do customization. We can do a micro monovision, we can do an EDOF, we can do a multifocal, as in how personalized the needs of that particular patient are. Whereas in an ICL or an IPCL, it is restricted. Monovision, we were all talking about. Monovision, again, will be able to give it for life for that patient in case we do a micro monovision for that patient or a full monovision for that patient with an EDOF lens in a clear lens exchange. And as far as getting a retinal detachment is concerned, all we need to do is make sure that that chamber does not get shallow and do a proper preoperative retina peripheral examination. Once that is done, we are absolutely clear. Otherwise, don't touch that patient. Otherwise, I would actually not even touch that patient for an ICL or an IPCL. But if the retina is absolutely fine, I see no reason why I would not go ahead with a refractive lens exchange. Thank you so much.
Thank you, Ron. That was quick and to the point. Thanks so much. Kamal, you have a chance for rebuttal.
Yeah, okay. I think a beautiful defense by both my juniors and friends there. One You see, hypermetropia is a gimme. Hypermetropia, I wouldn't want to do a phakic lens. So in case these opponents were careful when my slides were going, I excluded that. Now talking about sclerosis or lenticular sclerosis, again, ruled out. Now, once we say there is a cataract, again, I excluded that. If there is a cataract, I would not put a phakic lens. So that, again, I think that point is coming out of the blue. Now, the incidence of TAS, all over the world, studies say that phakic lenses, you do the least amount of tissue damage. There's no tissue broth. There's no cutting of the capsule. There's no floating anterior cortical matter. So the incidence of TAS, endophthalmitis, PC rent. Now, everybody's very smoothly mentioning the capsular, ignoring the capsular complications. Well, if somebody says they've never had a PC rent, either they're not operating or they're outstanding surgeons. Either way, they're standing outside the theater. So what if I land up with a PC rent while doing a refractive lens exchange? That possibility always remains. So for the other points where I do agree with my colleagues that, those are the situations even I won't touch with a 10-foot pole and do a phakic lens for a hypermetropic patient who has a small PSC, or patient who's not fit for the surgery over there. So I agree. So I swing on that side too.
That's being very fair, Kamal. From a senior person like you coming out to be fair, that's what we want, a fair answer, even though you're on the other part of the debate. Anything, VC, you would like to mention, sir?
Yeah, what I would like to mention here is we are all worried about the PCO, but what happens to the ACO? The anterior capsule also becomes opaque, and the anterior capsule becoming opaque makes the life difficult for a retina surgeon to detect any pathology which will kind of preempt retinal detachment. So treatment is difficult, diagnosis is difficult.
Now I'll ask a frank question to Kamal, Vinod, Sabresh also. Everybody who's doing ICL, IPCL, what is the incidence of anterior capsular cataract that you found? How often have you found? How many have you removed? How many have you extracted back again after putting an ICL and you regretted that you shouldn't have done it? Please, Kamal.
Okay, I forgot. In fact, I noted a point what Rohan said about, patients getting cataract and the series he's talking about. These are all the first model where there were no holes. The designs have changed. The concepts have changed. Now, coming to that, my true to heart, I have not explanted more than 9 lenses out of 3,180 IPCLs I've done. 3 of them were traumatic. 1 was a shuttlecock injury, and the other 3 were bad sizes. They were small lenses and they were touching. Period. Over. I think most of the cataracts we see in phakic lenses are due to bad sizing or surgical manipulations touching the anterior capsule. Period. Over.
Post 40. So you are almost convinced that minus all those negatives, you are not precipitating an early cataract in any of these patients.
If I've not fiddled with the anterior capsule, the problem happens is most of the time the poor lens gets the blame. Is the surgeon, while pushing in, that lens is rubbing the anterior capsule, the instrument is more aggressive, or the sizing is bad, or the aqueous flow is compromised, or the pupil is very small, is pushing the IPCL bad, or the hole is clogged. These things can cause, but by itself, I have not seen any patient like that.
Sabresh, anything you would like to mention?
No, I would agree. Sir, Rotmania, sir, please, after you.
No, Samresh, go ahead, please.
No, so I agree with Dr. Kamal. I don't do as much volumes as Dr. KBK is doing, but despite that, I have not seen too many. I've seen 1 anterior subcapsular cataract not operated by me and not progressing. So I'm just holding on to that, and I've explanted 1 because the lens was highly vaulted, and so I had to explant. So I don't do IPCLs. I do ICLs exclusively. So I wouldn't know, but the incidence is low. But that doesn't address the problem of presbyopia, and that's my only concern at this point in time.
Absolutely, agreed.
Ranjit, please.
Kamal, मराठी में एक म्हण आहे, म्हण, saying in Marathi. एक डोळं एक surgery. 1 eye, 1 surgery. That is the reigning credo. 1 eye, 1 surgery. The ethicality being the same in ICL or in RLE, 1 eye, 1 surgery should be your reigning model.
I agree, sir, but then we should operate all patients at the age of 21, 22, once their myopia settled.
See, the point here
then they won't need cataract surgery also, sir.
If you can get away with just 1 surgery in his lifetime, for that one eye.
So LASIK shouldn't be done, sir. Then LASIK shouldn't be done.
3,000 out of the 3,000 surgeries, how many were 40 plus?
I think more than 100 and I don't have the count, but probably near 200, 100.
So we are in hundreds here. Come on. We are in hundreds here. So that statistic is not really going to work well, right?
No, I get, but
So
these are the
this
patients.
paper also that I quoted actually said, so this paper also that I quoted actually said that this anterior subcapsular cataract is directly proportional to the age. The higher the age, the earlier it will come. So 40 is anyways a higher age.
So I would like to just add a point, even if there's no cataract, suppose there's no cataract in a myope or in a hyperope or an emetrope, but what are you going to do about the range of vision? Because if you do mini monovision, you're killing the stereopsis, fine stereopsis, and you're giving a level of compromise. And if you're doing a near complete treatment, I mean, there is no range. So 40-year-old is going to be 45 at some point in time, and 50 is not going backwards. But you have to give at least a solution for the next decade or two.
Absolutely. I couldn't agree more with you again, Samresh. That's why I said I gave 3 options. I play with 3 options. Now, if I have a patient who's a little shorter, I probably go in for a little undercorrection both the eyes. And believe me, a patient -7, -8, if he lands up with 0.75 or a 0.5 myopia, he does not have much problems for distance. And he's able to do a decent work. So a lot of tall patients, I may give micro mono. Depends on the height because of the arc length of the hand as they read. So I do play around with that. I have done 18 of presbyopic lenses in out of these 100 plus patients, and they're doing fine. And I've been doing this for over 10 years now.
Great pearls. I mean, I'm going to be looking at the height now. I wasn't till now, but I think that's a great.
And it make a huge difference. If you treat a tall patient, and even if you're doing a micro mono, he'll be happier with a lesser issues.
Okay,
last
question that I would like to ask the panel. You have a 24-year-old person with -8, -9, with a good cornea. Would you do a LASIK? Would you do any other, or would you do an ICL?
Define good cornea.
Oh, you have 580 cornea with a -8.
I think is good enough.
I'll go for a smile.
Okay, so that means I'm saying intraocular surgery, because the newer version that people are talking about now is saying ICL in a -8, -9 rather than ablating corneal tissue. So,
absolutely.
So what would you do?
Age.
28. That's what it said.
22, 24-year-old.
What is the keratometry, sir?
It's not, as I said, manageable. 47. You have a 47. It's not at 40 keratometry.
The ball is skewed. The ball is already skewed towards LASIK.
All right.
I have checked, Your Honor.
I'd like to take this question, sir. I'd like to take this question. Now, I have had these patients who are coming in quite often, and I give them a choice of both. And I tell them my first choice is to put an ICL, and my second choice would be to do a LASIK, preferably a femto LASIK or topo guided. The reason why they make certain choices is more financial than practical. But I do tell them I don't want to take out that much tissue. I would rather do a tissue addition procedure.
The quality of vision at a high myopia, sir, I'm sure we all will agree. In closed doors, you correct -8, change the corneal curvature from, even if it was 48. The mind was used to that curvature. When you flatten that cornea by around 6 to 7 diopters of flattening, it is going to affect the quality of vision, period.
All right. So
also,
we had
the downtime for a 20-year-old is difficult. Downtime of a...
I wouldn't do a cataract for...
Okay. Yeah, we are running out of time. Yeah, we have taken Dr. Lane's time, 2 hours instead of 1 hour. Thank you so much, everybody participating. Dr. Lane, sir, would you like to give your comments and the prizes, please?
Basically, I think it was an excellent discussion. I appreciate whatever they have presented, and I think once there is a debate, in debate all type of things will come, and I think really everybody has studied and they have got an excellent experience. So my comment is that in the what they are saying about the ICL and IPCL, so when the patient age is less, that is a 20 to 40, in these years I think it is better to go for ICL and IPCL. And if the age is more, that is 40, then you can go for the lens exchange. Before that, we should not go for the lens exchange. We have done the study of 100 cases, and I think the results are not good. So I think it is better, if it is possible, go for LASIK. If not, then you can go for the ICL or IPCL. And about the first and second debate, I think in only one question I want to ask you. In ICL, IPCL, who is the team? It means you want the Kamal and Samresh is a team?
No, Kamal and VC Mehta is a team, and
Samresh and Rohan.
Okay, okay. Then the in the first, I will go for the team. See, now I think the I'm giving only the scientific presentation and the discussion. The team, we three all. It means Ragini, as she has joined from the phone, so we could not spoke to her. But I think with me and Quresh and the Ranjit, we three discussed, and we have decided the team and also the first, second, third runner. And as three of we met, we have not got any money, so it is only the science. And in the science, the first team goes the multifocal. Multifocal is the best team because they have really put a science in front. The then the individuals who has good debate, the Rohit Om Prakash goes first. He has done a very good debate and clear understanding in him. Though he has implanted the VBT in the mother-in-law, but he has done a good work. And so Rohit is really did an excellent. The second thing, second goes runner-up is a Ramamurthy. Third goes runner-up is a Nitin. And fourth is Abhijit Desai. These are the teams. And here the ICL and IPCL. The team is the Kamal and this VC Mehta team. That goes the good team. But the debate and the clear understanding is Rohan Mehra goes first. He has done an excellent job putting the every science together. And runner-up is Samresh and Kamal. So these are the runner-ups here.
Thank you, sir.
So what is a discussion we had done, and this is the final. And I appreciate the effort by my secretary and my president of Bombay Ophthalmic Association. I really thank to each and every faculty who joined today and presented their presentation. Thank you.
Thank you.
Dr. Ragini, a few words from you,
everybody.
please. Dr. Ragini.
Wonderful.
Yes, sir. So it was a great. I mean, I'm sorry I joined a little late, but I really enjoyed it. I enjoyed the debates, and what the first topic that you chose for the webinar was really important. Like you said, that there are so many doctors who always have doubts and would like to learn from the experts. Everybody who joined here today were really very good, have done a lot of cases, were very frank and honest with their opinions. And the discussions were very good. And of course, the judges are my bosses, so I really enjoyed their comments too. Himanshu bhai, a great way to begin the new year, and I had the greatest time.
Thank you. Thank you so much for, we appreciate your presence, Dr. Lane sir and Dr. Ragini. Over to Manish. We can have a vote of thanks from Manish.
So the most pleasant task is to give the vote of thanks, and I would like to begin by thanking our judges, Dr. Lahane sir, Ragini ma'am, Quresh sir, and Dr. Manihar for attending the entire session and giving their valuable pearls of wisdom. I would like to thank all the 10 speakers. We gave them a very little time to prepare for this, but all of them agreed sportingly and chipped in. I would like to thank N.TOD for backing us up and supporting with the webinar. A special thanks to Dr. Pooja, Dr. Sumit Lane and Dr. Rohan for helping out with the creatives. They work very hard behind the scenes. I would like to thank all office bearers and the managing committee of BOA. I would like to thank all the participants, members of BOA, for joining in such huge numbers. And last but not the least, I would like to thank the boss, Dr. Himanshu Mehta, for coming up with this idea. This was a wonderful beginning that we made. Thank you so much, Himanshu sir, for coming up with this idea. And just one more announcement, this is not related to this webinar.
Thank you, Manish. Just can I interrupt?
Yeah, Abhijit.
Good out there in that background. G-O, your head, O and D.
Thank you so much, Abhijit. Thank you. So one thing unrelated to the webinar, we
Dr.
have
Ranjit wanted to say something. Ranjit, you wanted to say something. Please go ahead.
Yeah, taking on from this debate and ideas being floated here, Himanshu and Lahane sir, etc., a small expert group in the BOA or MOS, where a limited expert group, where people can actually post their queries, not a generalized one, but topic-wise, like you have selected 2 topics for a debate. The same way, a small expert group where you can look at some part of squint, some part of, say, what Abhijit does best is DCR and things like that. And this kind of an expert group could help the BOA in, getting people to interact with that group on a one-on-one basis. That's a takeaway, I think. And this was an excellent debate. It to start off the year, Himanshu, hats off. And every speaker was great. Every speaker was great.
Thank you. Thank you. Manish, over to you, Manish. You were saying
something. So I was saying something unrelated to the webinar. We have a IPL frenzy going on right now. Cricket fever is heating up things, and Himanshu sir has, he's got us a very good offer. We're getting some discounted prices for a game which features Mumbai Indians and the Gujarat Titans on the 12th of May. And we would be interested in knowing how many people are keen on coming and seeing this match together as a BOA group. Based on the response that we get, we will try and see whether to take this further or not. The costing is 4,000 rupees. That is the price.
Just
of the
a member or a spouse permitted.
Yes, sir, you can bring the spice.
Himanshu Varra, perfect.
Spouse and spice, everything, sir, you can bring.
Everything all together, Himanshu Varra.
It's 4,000 rupees
No.
ticket.
Himanshu nahi bhar raha hai. Individual Himanshu nahi bhar raha hai. Himanshu ticket la raha hai. जिसको आना है he should pay. हम देख रहे हैं कहीं किसी से पैसा मिलता है क्या? अगर मिल गया तो कंपनी से लेंगे, नहीं मिल गया तो खुद अगर देने के लिए तैयार है तो टिकट मिलाने का काम हिमांशु कर रहा है.
जो भी, thank you sir, thank you Lane sir for clarifying that for us.
Great support from Dr. Great support Manish from Dr. Lane and Manish to get this, and because it will be fun, 100 of ophthalmologists going and cheering and having fun. It's a sight to be seen. So please spread a word amongst your friend and personally message me or Dr. Manish that we know within next 48 hours how many are interested. Then we book the reservation because it's a lot of money.
Where are you going to be seated?
Sachin, Dr. Himanshu, I cannot take my leave because I have to go for a repeat MRI.
Kamal, you are also invited for the IPL, by the way.
Thank you.
Thank you. I've got to go for my repeat MRI.
Okay, just to thank him specially. He has sprained his ankle. He went for an MRI, went to the orthopedic. He's got a cast, but he's still here smiling with us all the way through. Thanks, Kamal, for your time.
Okay, bye-bye.
Manish, finish your announcement.
Yeah. No, so I just request that whoever is interested in the game, please send a DM directly either to Himanshu sir or to me, and we'll try and see how we take this forward. And we look forward to having more interactive sessions. And once again, a big thank you to Lane sir and our chairman scientific Ragini ma'am for guiding us. Thank you so much. Please have a pleasant week ahead. And we look forward to seeing you for the next BOA event soon. Closing words, Himanshu sir, then we call it a day.
Yes, thank you. First of all the participants who have been watching this show, I'm really thankful to them for getting us motivated to see that we have a wonderful debate. All the participants really participated with their heart. You could see the energy flowing when they were very, very adamant on their point. And these are such relevant issues. And of course, all the judges. I'm very thankful to Dr. Lane, Dr. Ragini, Dr. Ranjit Manyar and Kuresh for having spent their valuable time despite their busy schedule to listen to the whole thing and get the judge so well. Thanks, sir, Dr. Lane and Dr. Ranjit Manyar and Dr. Ragini. Thank you, Manish. You have been a great backbone and support for getting the whole thing executed. Much appreciated. And of course, NTOD for having this initiative to get us going. And all the prizes are also sponsored by NTOD. We really appreciate Mr. Kishore Masurkar and Raman, who has really gone through the whole thing.
Thank you.
Could you, all the prize winners, could you just text your addresses because we'll fast the the prizes to all the winners. Can you please text your addresses on Manish or me, whatever?
Yeah. Please do that.
Yes.